The next session, it is complex cases in post-kidney transplant and interactive session. Today we have 3 cases. The first case will be presented by Dr. Thidarat from Bhumilaj Naklin Kidney Institute. Dr. Thidarat, please.
Good morning, Professor Adnan Sharif. สวัสดีค่ะอาจารย์วชิราอาจารย์กิตาพลแล้วก็อาจารย์สุรศักดิ์นะคะ and good morning everyone. แล้วก็สวัสดีอาจารย์จักรพัฒน์ด้วยนะคะ as we have done over 200 cases of kidney transplant and I have met some difficult and complex case. So today I would like to share the complex case in post-kidney transplant in Bhumilaj Naklin Kidney Institute. We have 3 cases and I would like to start for the first case. This case is my patient, very complex. A Thai male patient, 60 years old, ESKD, likely from DKD, type 2 diabetes, hypertension and obesity. For the BMI is around 30. He has done kidney transplant deceased donor since June 2024. And donor, he is a male, 53-year DBD donor, as we don't have the DCD donor in Thailand. KDPI is 63 and has severe AKI. For immunologic risk, HOA mismatch is 1, 2, 2, 0 PRA, cross-match was negative, CMV, IgG, donor positive, and recipient was positive. Induction regimen is basilizumab and methylprednisolone and maintenance with the tacrolimus, MMF, and prednisolone. For ischemic time is around 17 hours. For post-operation period, the patient has developed delayed graft function as expected. We have done a kidney biopsy at around day 9. We have found an acute tubular injury. There's no rejection. And after that, the allograft is recovery. Double J stent was removed at 1 month after kidney transplant. For the baseline creatinine is around 2 to 2.2 milligram per deciliter and or 126 to 194 millimole per liter. Today I will present in both of units at in the UK. In the UK use a millimole per liter for creatinine unit. Best creatinine is around 1.83. And after kidney transplant, the patient has lymphocyte and has to do the laparoscopic peritoneal window around 1.5 months after kidney transplant. And after that, creatinine still creeping, rising to 2.45 milligram per deciliter. At that time, we have test for DSA, and that's negative for class 1 and class 2. And here is the timeline of this case. As you can see, the creatinine is still creeping to 2.45 with a tacrolimus level between 5 to 6 or 5 to 7. And at that time, after creatinine rising, I have tested the BK viral load. Actually, that I do the interval surveillance, but that's not detected before. This is the first time that we have detected the BK viral load. That peak is just only 665. And during BK at that time, what test is more than 160 million at that time. So this case has BK viruria with a low titer of BK viremia. Ultrasound Doppler renal transplant was done, and there's 2 patent vascular flow of transplant kidney. There's mild increased RI resistive index, and slightly to my increased echo of transplant kidney with increased dilatation of renal pelvis. And this is the ultrasound. As you can see, the patient has developed the hydronephrosis. It's mild hydronephrosis. So I consult to the urologist here, and MR urography was done. From MR urography show transplant kidney that has a small localized fluid collection around 2.6 centimeters, but to transplant ureter. And there's some patchy strands with no gross mass information at renal sinus and around renal pelvis of transplant kidney, and highly suspect inflammatory lesion. And its extent surface to narrow and compressed UPJ resulting mild hydronephrosis. As you can see here, there's a patchy strand and can cause the renal pelvis dilatation. So urologist and team decide to do the antegrade pyelography, and this show delay excretion of contrast and narrowing of upper part of transplant ureter. And the double J stent was placed. At the time, I think that everything's gonna be better, but it's not. After that, after DJ stent was insertion, creatinine still creeping and rising to 2.68. UPCR was creeping too. And actually that I follow the BK viral load at that time is become to not detect in the blood. For the other investigation, for the CBC, that you can show hemoglobin is around 10.6 and hematocrit is around 33. Platelet is normal. And UA, there's no red blood cell, no white blood cell. So the probability of this case is case of DDKT 5 months with creeping creatinine rising, and history of DGF and BK viremia with low titer BK viremia, and obstructive uropathy, suspect from BK virus at that time. And we switching immunosuppressive regimen to low dose CNI with mTOR after we suspect of the BK uropathy. But after that, after we switch the immunosuppressive, the creatinine is still rising. So I decide to do the second kidney biopsy. And here this is, we can see this, here this is a severe IFTA. And here this is a cortical necrosis. And mucointimal thickening with fragment red blood cell. And here's the show tubulitis with atypical tubular nuclei. So you know, right, what's happened. Here again, tubulitis with atypical tubular nuclei. For the IF, we're all negative, and C4D, and no staining in PTC. For the SV40, that's positive, but less than 10%. So the pathologist report the kidney biopsy that there's a focal acute cortical necrosis associated with subacute thrombotic microangiopathy of arteries and polyomavirus nephropathy of BK1 class 2. And there's no rejection from kidney pathology. Here, after kidney biopsy was done, and I found that there are two diagnoses in the same kidney pathology. So for the BK1, I switched the regimen to extend release tacrolimus and sirolimus to tackle the BK virus. But after that, the creatinine is still creeping. And I have to discuss with the patient that he's nearly to do the hemodialysis again. Maybe we cannot save allograft at all. But because of from the pathology that show the TMA. So at that time, I think that nothing to lose. So I decided to switch the regimen again. I switched from extend release tacrolimus and sirolimus to avoid the tacrolimus-induced TMA, I switched to cyclosporin and MPA and prednisolone at that time. And that's amazing that the cause of creatinine rising at that time is, I think, is because of TMA for the majority. After I switched the regimen, the creatinine was running down, and in just only 2 weeks, 1 month after that is better and better. I have surveillance for BK viral load is still not detected, and urine BK is coming down. We follow this case for around 1 year and a half. 1 year and a half. The creatinine right now is around 2.7, and actually the best creatinine is 2.2. For the UPCR is decreased, and BK viral load is still not detected. So diagnosis of this case is DTKT for 5 months, obstructive uropathy that we are suspect from BK virus, as we know that BK uropathy can cause obstructive, and furthermore, this case we have diagnosed the BK van. Even that's quite atypical because there's no BK viremia in high titer. It's just very low titer and just transient. And the final diagnosis is TMA, and the cause of the TMA that would be associated with tacrolimus, as is very well-known drugs that can cause a TMA after kidney transplant. And after we withdraw the tacrolimus, after that the creatinine was coming down. Everything is better. So this is the first case that I would like to share. Thank you.
Okay. Thank you, Dr. Tidarat. May we have a short discussion, Professor Adnan, please, about this case. What is your diagnosis and management for this case? It's quite complex because they have many diagnoses like cortical necrosis, microangiopathy, and polyoma virus nephropathy, and obstructive uropathy too.
It's very difficult, and I mean, you did really well.
Thank you very much.
To manage that, and I think, I mean, BK, we're seeing a lot more BK in our patients, and we've for the last few years we've been starting to screen all of our patients for the first 2 years. And we find that most patients are getting BK around about kind of between 6 to 9 months. And how we manage those patients is very difficult. And we all do different things. And the guidelines all say just lower the burden of immune suppression, but we all do different things. And I mean, it's interesting in this particular case that the cyclosporin switch worked so well. So I did part of my training with Bob Montgomery when he was at Johns Hopkins, and they did the incompatible transplant program, which started in, I think, 1998, and they did protocol biopsies on all their patients, and they went back and they checked through all their biopsies, and they found that when patients were on MMF and steroids, there was no BK. And the BK only started when tacrolimus replaced cyclosporin. So this switching to cyclosporin for BK is what they did for their patients as well. So I think that's a really good kind of strategy to use. And I mean, tacrolimus is fantastic, but I think when people get problems, it's important to be able to kind of change it very, very, very quickly. And I mean, obviously, the kind of ureteric complications with BK is kind of very well known. And I think every center now uses stents. Some people feel that the stents may be a risk factor for BK, but I think it's now just a standard thing to do. But now very difficult with lots of different pathology.
Thank you very much. And this case, the DJ stent was removed after around 9 months. And we follow up until now, the hydronephrosis still is still not recurrent. So this case, I'm very happy to help him to be good like today. Thank you. For the next case,
For the next case, so we
Thank you
proceed
very
to the
much.
next second case will be presented by Dr. Thatchai.
Good morning, everybody. Good morning, colleagues. I welcome you and appreciate your presence. Today, we will discuss the adaptive technique for the kidney transplantation with an emphasis on the specific challenges encountered in the patient with ileal conduit. We will also examine methods to salvage cases complicated by a hostile abdomen. First of all, I want to introduce about the ileal conduits, which creates a surgically formed pathway for the urine transfer from the ureter to the abdominal stroma of the dependent urinary outlet for the patient experiencing lower urinary tract issue. However, they result in an iliac fossa that is scar and potentially contaminated from pure surgical procedures. This combination presents unique surgical challenges that will be addressed throughout this discussion. Okay, let's look at a case that highlights the breaking point in these procedures. A patient who had been dependent on hemodialysis for 6 years followed multiple episodes of urosepsis. Subsequently, underwent ileal conduit urinary diversion at the age of 32. In February 2025, an attempt at the DKT was undertaken in the right iliac fossa. However, dense adhesions resulting from the prior conduit surgery led to an intraoperative small bowel injury. The risk of the significant contamination was considered too high to proceed with the procedure at the time, resulting in its termination. Okay, we back to the concepts of the hostile abdomen is introduced, representing the considered surgical challenges encountered following the procedure and the presence of scarring. In such case, the focus shifts toward salvage kidney transplantation. The objective is to identify innovative strategies to achieve successful transplantation despite the adverse conditions. Okay, we look at the single center experience of 59 cases from the Manchester Royal Infirmary. They found that the long-term graft and patient survival are comparable to the normal transplant populations, despite increased initial complication rates. The standard procedure in this paper involved the positioning the kidney graft nearest the graft to ensure that the ureter follow the shortest possible route to the conduits. In terms of the urologists, when we perform these complex operations, the technical execution of the anastomosis is everything. First, vascularity is our primary concern. 2. We must ensure that anastomosis is tension-free. 3. A mucosa-to-mucosa technique is essential for proper healing. And the last one, we use precise suture placement to avoid compromising the lumen diameter. The upper and mid portion of the ureter receive blood supply from the branch of the renal artery, whereas the lower ureter is supplied by branch from the vesical artery. Consequently, preserving the cranial ureter artery is essential for achieving a well-vascularized ureterostomy. During kidney transplantation, particularly emphasis must be placed on protecting this artery. Therefore, the transplant ureter should be kept as short as possible to maintain its blood supply. This approach facilitates a healthy, well-vascularized ureterostomy. For these reasons, the clamps should be positioned as close as possible to the conduit, ensuring optimal vascular preservation. In our salvage case, we had to pivot. Instead of the scar-like size, we moved to the left iliac fossa. This area was isolated from the previous inflammatory environments, provide a safe haven. Choosing the left side isolate the graft from the hostile zone, but presents a longer distance to bridge the ideal conduits. This longer path increase the risk of the technical complications and operative failure. So we have to balancing contamination risk against the technique demands is a key surgical decision in this case. We adapt our approach to overcome the challenges of the hostile abdomen. 1. Position the renal graft in an upside down orientation to optimize the access. 2. Instead of going back into the conduit, we perform the anastomosis between the transplant ureter to the ipsilateral native ureter. The key element of our adaptive strategy are demonstrated here. The renal graft is positioned in an inverted orientation to enhance surgical access. This configuration optimizes vascular targeting and prevents ureteral kinking. Additionally, a short ureter is utilized to preserve the cranial ureteral artery, which is vital establishing a well-vascularized ureterostomy. The choice of the ureterostomy connecting the transplant ureter to the patient's native ureter also allow for the preservation of the cranial ureteral artery, facilitating a robust, well-vascularized anastomosis. Each of these steps is essential for ensuring a safe and functional anastomosis in this complex clinical setting. This is the I intend to compare the actual intraoperative finding with the diagram. Two fundamental principles underpin the success of this approach. First, achieving attention-free anastomosis is critical to prevent the leaks at the stricture. Second, maintain robust blood supply, ensuring proper healing and long-term functions. Okay. After this, let's look at the real-world results of this approach. Here we see the patient's serum creatinine fall sharply from a baseline of the almost 15 to 2.4 within a week. This immediate drop is a strong sign of the early graft function. Doppler ultrasound confirm the perfusion with the good perfusion with no evidence of the hydronephrosis. At the 1 year follow-up, the patient remained critically stable with a serum creatinine level of 1.7, indicative of the preserved graft function. We performed the weekly Doppler ultrasound continue to demonstrate excellent perfusion with no evidence of hydronephrosis. Although there was a single episode of the urosepsis at 9 months post-procedure, it was managed successfully without the need for additional intervention. Most importantly, the patient reports substantial improvement in quality of life. This finding support the long-term viability. This adaptive approach be successful restore the renal function and safeguard the urinary tract. In summary, when facing a hostile domain, there be effect to 1. Avoid the hostile. Scar zone by using left iliac extraperitoneal approach offer both safety and technical ease. 2. Rethink about the orientation. Use inversion to your advantage. 3. Bypass the conduit. Utilize the native ureter when necessary. This adaptive strategy can make all the difference in complex operations. Thank you for your time.
Thank you. Dr. Thatchai is very interesting case with good result with complex surgical cases. So may Professor Adnan comment a little bit about this case? It's quite rare.
Cool, thank you. I mean, obviously, I'm not a surgeon, but it's a real challenge now, isn't it? With kind of, I mean, as you describe it, a hostile abdomen and kind of trying to balance the safety of trying to be able to kind of manage that kind of, and then the complications that come afterwards. And I mean, we are seeing more and more of these surgical challenges, and especially for us. I mean, obviously here there was already some kind of pre-existing neurological history. And we've got a lot of these kind of challenging, especially children who've had a lot of procedures and in adulthood when they have a background of urological problems. They may have already had one pediatric kidney transplant, and often my surgical colleagues are seeing them for their second or third kidney, and they already have an ileal conduit, and it's a real challenge sometimes. And I think it's it's very, very easy for us kind of as nephrologists kind of I always tease my surgical colleagues that what you do is very easy and I could do it. But that's because they're friends, and it is very it is very difficult, and I think it's a challenge that we're going to have going forward, because we're going to have more and more complex surgical candidates for transplantation.
Yes. Okay. Thank you very much.
Okay. Thank you, Dr. Thatchai. May we proceed to the third cases. The case will be presented by Dr. Kanitha Thienkanon.
สวัสดีค่ะ I'm Kanitha Thienkanon นะคะ This is our third case, which will be an introduction to our next speaker นะคะ Okay, so this case is a common case that we found every day in the post-transplant clinic ค่ะ This is a 24-year-old Thai male cadaveric kidney transplant. It is his first time. His SLA mismatch was 2-1, 0 PRA and cross-match negative. The induction therapy was IL-2 inhibitor and palmethylprednisolone, and the maintenance was tacrolimus and mycophenolic acid. The recipient underlying was IgA nephropathy, hypertension, and his special condition was hemoglobin H thalassemia. During his dialysis period, he needs high-dose erythropoietin stimulating agent up to 20,000 units of EPO alpha and regular blood transfusion. Despite all that, he still has 0 PRA. And also the fatty liver and gouty arthritis. About the donor, he's a 21 years old group B Rh positive donor with history of rupture AVM, and the creatinine was 0.89. The total ischemic time was in the regular range. There was no immediate surgical complication, no delayed graft function. The first 2 weeks after transplant, his creatinine was rising a little bit from 1.9 to 2.5. So we do the surveillance biopsy showing no rejection and nothing. So we do the screening PRA after the transplant still negative. ค่ะ 2 months after transplant, he has developed BK viremia, but it was easily controlled after we decreased the dose of tacrolimus. ค่ะ and the BK was suppressed, keeping the level of tacrolimus to 5 to 6, which this period considered a little bit early to decrease to the low dose tacrolimus. His renal function was stable around the creatinine about 2.0 until 2 years after transplant. This is his lab result at the OPD. He developed a little bit increase of his home blood pressure, and he developed anemia, including the rising of creatinine and new onset proteinuria. During that time, we trying to keep the tacrolimus level at about 6 to 7, and we increase the dose as the table show. Until on the October, his creatinine reached 3.1, so we do the allograft biopsy. And the kidney biopsy shows he has chronic active antibody-mediated rejection. At that time, the chronicity of the allograft, he has about 3 out of 16 glomerulus has global sclerosis and about 30% interstitial fibrosis and tubular atrophy. At that time, this is what his allograft looks like. A lot of glomerulitis and interstitial nephritis. Also, his PTC score was 3. The result of anti-HLA antibody come out positive for HLA class 2, DR53 of MFI units of 12,000. That time we initiate the treatment of ABMR. He received 5 cycles of plasmapheresis. We choose the double filtration plasmapheresis technique due to his current body weight. His plasma volume was almost 5.5 liters. And if we choose the regular plasmapheresis treatment, it will be a lot of fluid supplement. And he received 2 grams per kilo of IVIG. After that, we increased the dose of his tacrolimus level. So after the treatment, the patient still experienced high blood pressure. We titrate the dose of his antihypertensive drugs. And the creatinine seems to respond. The creatinine, the allograft function seems to lower a little bit, but the proteinuria persists. It's more than, the PCR is more than 1,000 milligrams per gram creatinine. And he experienced anemia. Usually, the past 2 years of his transplant, he only needs about 3,000 units of erythropoietin alpha per week. But after the rejection, the needs of EPO need to be increased up to about 10,000 units per week. So 1 month after the treatment of transplant, due to the proteinuria, we do the second biopsy of the allograft showing the same presentation. The chronic ABMR still persists, but we see less active lesion. His score of glomerulitis decreased to 1, and it's starting to change into a chronic form. He has the CG score of 3, and the glomerular sclerosis increased a little bit, but the interstitial fibrosis and tubular atrophy score is increased up to 60 to 70%. So we discuss with the patient. We redo the anti-HLA antibody to see if the scoring MFI was still high. It came out about 8,000. So we discussed with the patient and start the anti-CD20 treatment, low dose rituximab, was given to the patient after discuss. After receive the anti-CD20, this patient has experienced anemic symptom. His hemoglobin starting to drop drastically without any blood loss or any hemolytic symptom, and his white blood cell starting to decrease. Apart from that, due to his anemia, it affects his tacrolimus level. So you can see we need to increase the dose of tacrolimus. He is one of the non-high metabolite tacrolimus patient. Before, he only needs 2 milligrams of tacrolimus per day to maintain his trough level. But right now, we increase the dose up to 4. And we regularly checked his infections, CMV, and BK red alert still not persist. So in this patient, the therapy of antibody-mediated rejection he was given was to decrease the anti-HLA antibody, the plasmapheresis. He received the IVIG, and as from current practice, the definite treatment of chronic antibody-mediated rejection still individualized and arbitrary. So next speaker, our Professor Nathawood, will be discussed about this issue. And the problem of this patient is right now, even though he received the anti-CD20 and experienced some side effects of the drugs, such as anemia and neutropenia, right now his creatinine has returned to baseline, but he experienced a lot of proteinuria, about 1,500 up to 2,000 milligrams per gram creatinine per day. So, and also he experienced his hemoglobin H disease has a lot of anemia, and he needs high dose EPO alpha. So I would like to ask Professor in this meeting to have some comments on this case. Thank you.
Thank you for for that presentation. I mean, I know we're going to get a kind of a lecture on chronic AMR, and it's a real challenge, isn't it? I mean, it's been very difficult to manage these patients, and I mean, we have the same options that you have available here, so plasma exchange, IVIG. We try to optimize the immune suppression, but again, like your patient, they've seen the effects of over-immune suppression with the BK and then the effects of under-immune suppression. But I mean, we are in a slightly better period now where there's new molecules being targeted. And I mean, I was chatting yesterday, we are participating in some of these trials now which are targeting various aspects of chronic AMR. If they're successful, how expensive they are, I don't know. But I think, I think it's going to move as a field over the next few years. So it gets exciting time for us with transplantation.
Okay. So the treatment is more challenging and more difficult, but prevention, is it possible to prevent chronic AMR? For example, or early detection of this condition?
So prevention is always better than cure. The difficulty is there's no proven way to be able to kind of prevent it. I mean, some centers used to routinely check for donor-specific antibody. And I know in some places in the US, they still do that. I mean, now they've got cell-free DNA, which, to be honest, we don't do that in the UK. But we did a trial in the United Kingdom called Outsmart. And it was a 2 kind of stage trial. And it was about 4,000 patients. And the first question was, is there any clinical benefit from routinely checking for donor-specific antibody? So if they are clinically well, should you, every 3 months when you see them in clinic, should you check for a donor-specific antibody? That was the first question. And then the second question is, if you have a patient who is clinically stable creatinine, but they have a positive donor-specific antibody. If you change their immune suppression, does that lead to any clinical benefits? And it was a negative trial. So there was no advantage from checking routinely for DSA. And it was a double-blind study, so the clinicians either some knew that there was a DSA and others didn't. It made no difference. So if you have a stable creatinine, increasing the immune suppression doesn't actually lead to any graft benefits. So we've stopped routinely checking it. Now, obviously, some people are saying you should check cell-free DNA, and it's a similar thing. There's no evidence that, and cell-free DNA is very expensive. And unless you can show it leads to some benefit for the patients, I think it's very hard. But I do feel that we over immunosuppress our patients more than we under immunosuppress them. I think we see more problems with things like infections and cancers than we probably do with rejection. 20 years ago, it was more the other problem. We saw more rejection than we did infections and cancers. I think that's our big challenge. How do you get the immune suppression just right?
Okay. Thank you so much. So we move to the next session. The topic will be presented by Associated Professor Nattawut Tonamchai from Chulalongkorn Hospital. The topic is novel strategies to prevent DSA and chronic antibody-mediated rejection. Dr. Nattachai, please.
Thank you, Professor Surasak, and สวัสดีครับ Professor เกรียง Professor ธีรชัย Professor กิดาพล and Professor Sharif and audience. Today is my great pleasure to talk about strategy to prevent chronic ABMR, which is pretty hard and hot topic right now for transplantation. Maybe after finish the talk, there will be some more question left to you because I cannot answer the question about this topic. This is my disclosure. Actually, I prepare my slide for 40 minutes, but right now I will cover everything, try to finish in 20 minutes to give back the time for the meeting. So we will start from the classification of the DSA. According to the DSA, we can classify by strength of the detection. We can divide that into CDC ASG and flow cross-match, which now in Thailand, we move to flow cross-match already, and or Luminex detection. And for the evolution of the DSA, we can divide it by P-form DSA and de novo DSA. And the pathogenicity, which is we not start to do it yet. We can do it now, but it's pretty much expensive. But we can divide it into complement binding, according to complement binding or IgG subclass, and we can divide the DSA according to the class by class 1 or class 2 as well. Start from the strength of the DSA. We all know that the more the DSA, the more the problem that we can give. Okay, I will finish with that. Now move to the second one about the preform and de novo DSA. For the preform DSA, we can divide it into resolved DSA and the persistent DSA. Let's take a look at it. Shown here, this is 4 types of the DSA by divided into the evolution of the DSA. We would like our patient to be like this without DSA at all, before transplantation and after transplantation. And the de novo DSA is those patients who before transplantation have no DSA at all, but develop DSA after 3 months or 6 months after transplantation. And those patients who have preformed DSA, we can divide them into 2 groups according to the resolution of the DSA. If the DSA can be resolved, those patients we call resolved preform DSA. One study, they look at the patient who have DSA, divide patient into those who have DSA or not to have DSA. Those who have DSA have didn't underwent desensitization. We found that those patients who have DSA positive before transplantation have rejection rate almost 50%. This is without desensitization. But those patients who has no DSA have only rejection rate about 9%. And when we look at the long-term graft outcome, those patients who have pre-transplant DSA have worsened the graft outcome compared to the pre-transplant DSA, negative. And in those patients who have pre-transplant DSA, some of them can be resolved after transplantation. And with the outcome, those patients who have resolved DSA after transplantation, the long-term outcome is pretty similar to those patients who never have DSA at all. And what about the persistent DSA? Those patients who have persistent DSA have a problem in the long-term graft survival, and the persistent DSA usually related to the pre-transplant DSA class 2 and the high MFI value before transplantation. For those patients who have pre-transplant DSA, first of all, we have to desensitization to lower the DSA as much as we can to list the problem before we get the patient to transplantation. Okay, this is preform DSA. And what is the factor that likely to be pre-transplantation DSA to become persistent and not resolved after transplantation is the high MFI before transplantation and the DSA to the HLA class 2, especially DQ. And now I would like to move to the de novo DSA, or those patients who never have pre-transplant DSA at all. This is a landmark study more than 10 years ago from Canadian group. They monitor DSA before transplantation and then after transplantation. I will not go through in the detail, but from this study and many more studies, we all know that the de novo DSA can worsen the graft outcome. And shown here, this is the conclusion about the risk for de novo DSA to development. Okay, and what about the immunosuppression? Some study, like benefit study, has been shown that the belatacept can lower the DSA, de novo DSA compared to the standard regimen. So we have to try our best to lower the risk factor for de novo DSA. Shown here, this is the study that Professor Sharif has been talked about. This study showed that monitoring the DSA after transplantation, they divide patients into two groups. The first group is the patient that has monitoring DSA, and the physician know the result of the DSA, and then adjust the immunosuppression, try to manage the adherence of the patient, and try to increase the dosage of MMF to the maximum dose. What happened? In the intervention group, monitoring DSA increase the immunosuppression. They reach the outcome just only by decrease the rejection for the patient, but the long-term outcome, according to the graft failure, not different compared to the control that didn't monitoring the DSA. For the pathogenicity, I will not touch today because it's a little bit far for us for routine usage. And now move to the class of the DSA. When we divide the class of DSA into class 1 and class 2 antibody, the class 1 antibody more often to go to complement-dependent cytotoxic rejection compared to the class 2 DSA, most go to the antibody-dependent cellular cytotoxic. Shown here, this is the classic class 1 that cause rejection. The DSA can fix the complement, and this can cause rejection and show the C4d positive compared to the class 2 antibody that most of them go through the antibody-dependent cellular cytotoxic, and many cells can come to the graft, and sometimes this cause C4d negative rejection. Shown here, this is when we divide the patient into two groups according to the HLA antibody, and you can say that linkage between the class 2 antibody and the de novo DSA, and the chronicity and the graft failure. So right now, the HLA class 2 is the main problem in the long term. We can fight against the HLA class 1 or pre-transplant antibody, but the long-term outcome about the HLA class 2 remain the problem. Anyway, shown here, this is the incidence of de novo DSA after transplantation, which is around 10 to 20%. And luckily, only half of those patients who develop de novo DSA will have chronic ABMR, half of them. Okay, so let's take a look at here. This is de novo DSA and the persistent DSA here. Only around 50% of those patients who have DSA will develop chronic ABMR. So how can we prevent chronic ABMR? The best way is to prevention the development of the DSA. First of all, we have to manage the risk of de novo DSA by adequate immunosuppression, by low patient viability duct, and the adherence for the nephrologist that taking care of patient is the fifth vital sign of patient. Always, you have to check 4 vital signs, and another one is the adherence of the patient, every visit of the patient, to make sure that the patient adherence pretty well and no de novo DSA develop. Another thing is about those patients who have preformed DSA. Improve the HLA typing, epitope matching, and avoid the unacceptable HLA and desensitization in living transplantation can improve or try to resolve the pre-transplant DSA. So this is how to prevention the chronic ABMR in patients without pre-transplant DSA and in patients who already have pre-transplant DSA already. I will skip this because I mentioned everything in this all slide already. Okay, this is my first half of my talk. And the second half is what about the recent update in diagnosis and management of ABMR? This is not prevention for ABMR, but this is for management of the ABMR. In 2019, the TTS working group published the guideline in treatment of the ABMR by divided the patient into the early ABMR and late ABMR. And most of the time, the treatment focused on antibody reduction and by using desensitized apheresis technique, IVIG, and rituximab. And after that, according to the diagnosis of ABMR at that time, there's some patients who have only MVI, microvascular inflammation, without detection of the DSA, and C4D has been negative. At that time, many studies have been published according to the prognosis of the MVI without DSA. And some studies have different outcome. So in BAM 2022, they have the new diagnosis, categorize the patient who has been have microvascular inflammation but has negative DSA and C4D. In 2019, we categorize this patient into no ABMR. But anyway, any inflammation in the graft always have some problem. So they categorize this patient has no BMR, but they have the new category into the MVI without DSA and C4D. Okay, let's take a look at this new category, which sometimes we find this MVI in our patient. What is the cause of MVI? The cause of MVI can be divided into 3 groups. So MVI without DSA positive. First of all, is about the technique of HLA detection. Shown here, this is the technique that we can miss the DSA detection. The DSA is there, but according to the technique, we cannot detect the DSA. So we diagnose this patient into DSA negative MVI. And I will not touch about the non-HLA DSA today. And another thing is the new new territory and new knowledge about that we have to study right now. We learn about T cell, we learn about B cell in transplantation, but right now we have to know the NK cells as well. So another reason of the MVI without DSA right now is the NK cell activation. Shown here, this is the biopsy result of the patient who have microvascular inflammation, glomerulitis, and PTC, capillaritis, and they stain on the CD56 that you can see the NK cell infiltrate in the graft, not just the T cell or cytotoxic T cell or any kind of plasma cell. Right now, we have to know the NK cell. From this HLA class 2 that have chronic antibody rejection, you can see that in the antibody-dependent cytotoxic, the NK cell is one of the problems that the cell that infiltrate and make inflammation to the graft. So in 2025, the study from the group that draft the BANF guideline 2022, they study the new category, the MVI with DSA negative, and they look at those patients who has been diagnosed as non-rejection, but changed to the dual diagnosis in 2022 to the MVI DSA negative, and they found that even without in this patient, we have no rejection. We have to know that none of patients that categorized in the MVI have been treatment for rejection, and the graft failure has much higher compared to those patients without any inflammation in the graft. And the MVI have pretty similar graft survival to the ABMR patient, but we have to admit that the ABMR patient has been treated at that time as well. So compared to no inflammation in the graft, those patients who have inflammation or MVI have higher risk to have the graft loss and pretty close to the ABMR with treatment. And the MVI is not just stop that. Those patients who have MVI can develop evolution to become the ABMR as well. Even ABMR or transplant glomerulopathy. So the new classification, the patient that have MVI without C4D and DSA positive sometimes may not caused by the anti-HLA, and treatment that focusing on the anti-HLA or removal the antibody may not work. So the potential mechanism of the MVI can be innate immune response like NK cell and T cell, and we have to look at the phenotype of the patient as well, that they have clinical or subclinical. In summary, MVI, any inflammation in the graft always has the problem, and the cause of the MVI mostly is the HLA class 2. This review focus on the new treatment for the ABMR that mainly focus on B cell, plasma cell, and antibody. In this first half, the treatment focus on DSA prevention, and in this second half, focus on the DSA that already happened to the patient. And in this small box, I will focus on the NK cell. The NK cell is the lymphocyte that have cytotoxic but innate like. You can find NK cell anywhere in the peribus smear, in the tissue, in the lymph node. And how the NK cell killing the germs or the other cell by the missing cell or induced cell and the outer balance model that has been proposed for the NK cell. Like this kind of cancer cell, the cancer cell that still shown up the HLA class 1. We all know that every cell that have nucleus in our body can show HLA class 1. If they show HLA class 1, the cell that can come and kill this cancer cell will be CD8 cytotoxic T cell. But if the cancer cell not show up the HLA class 1, it's the time for NK cell to clean it up, because this called the missing cell, mean the cell that not show the HLA class 1, and the NK cell will be target to kill this kind of cell. And you can see the NK cell use the KIR, the killer inhibitory receptor, to detect the HLA class 1. If the KIR can detect class 1, this NK cell will be inhibited. There was a lot of receptor around the NK cell. And right now, the best theory in terms of describe the function of the NK cell is the outer balance. The NK cell will balance between the inhibitory signal and the activation signal, and it will decide to kill or not to kill the cell that it contact. So the NK cell in transplantation can be found in the MVI DSA negative or the chronic ABMR as well. And with the anti-HLA antibody that can point to the graft, like the laser point for the air to make the bomb to the target like this. This is like an NK cell and anti-HLA antibody to work like. And now we have the medication that hematologists already use for multiple myeloma. We call the anti-CD38 that can be expressed in both plasma cell and NK cell. I will skip this part. Many new medication like daratumumab or felzartamab that has been shown that to decrease the DSA, the rejection and the inflammation from the allograft. There's many more study about the anti-CD38 will come, and this has been published in New England Journal, shown that the felzartamab is safe and can lower the inflammation in the allograft from those patients who have rejection. Another thing is this shown the intracellular signal of the NK cell, and one of the activation signal that go through the NK cell, according to the missing cell signal, they go through mTOR signaling as well. Shown here, this is a study show that the mTOR complex 1 will activation has been found in the NK cell that had been activated by the missing cell signal shown here. And the mTOR inhibitor had been shown to prevent the missing cell signaling for the NK cell rejection. So from the 2029, the TTS group, and this year there's another group had been proposed the update treatment for the ABMR by only these apheresis or antibody removal or for just the acute rejection patient. But for those patients that have late rejection, only optimization of the immunosuppression that we can do for the patient. We need more data, we need more study to show how we can optimize the immunosuppression for the patient. And they proposed the role of anti-CD38 antibody as the adjunctive therapy. Shown here, this is the conclusion. The change from TTS 2019 guideline to the 2025 that published in NDT. The role of corticosteroid had been removed and just only in those patients that had T-cell rejection. The role of rituximab has been lowering down, and the role of anti-CD38 has been proposed together with the mTOR inhibitor in those patients who have MVI. In conclusion, to prevent the late ABMR, we have to try to lower the risk of de novo DSA and try to lower the pre-transplant DSA as much as we can. But in patients who already develop the DSA after transplantation, there is no good study for the ABMR prevention. It's around 50%. They will develop chronic ABMR. And the MVI is the new new category that has risk for progression to ABMR. There's a low of NK cell, and the treatment of late ABMR still have question how and how. Thank you very much.
Yeah, very interesting lecture. A lot of questions and answer to be addressed, right? So, Professor, have you any comments about this topic? Challenging, right? Because mTOR inhibitors, I haven't seen the study in clinical transplant that it can prevent ABMR, even though in the cell study that you present is just a laboratory assay, right? That mTOR may play a role in the signaling pathway in mid-cell or rejection, right?
Yeah, great talk, and I mean, you did really well to kind of shorten it to 20 minutes. I mean, it's such a big topic, and there's so many things to kind of look at. I was mentioning yesterday, I mean, the use of rituximab, for example, for acute AMR. We were supposed to do a trial in the UK where we were going to compare centers that, well, because right now everyone uses rituximab in very different ways, and so we were going to do a trial of plasma exchange IVIG with or without rituximab, and that received funding, but then it was just before the pandemic, and we weren't ever able to do it. So that question is still unanswered. But there's so many new molecules now being targeted for chronic AMR, which is really exciting. And we have a patient who's just been recruited to the new C3 inhibitor trial, which I think Alexion is doing. So I think that's the ALXN 2030 trial. So that's a brand new molecule. And again, eligibility is chronic active AMR, and you have to have a GFR of 30 and above. And I think that's the other problem there. A lot of these patients that we see, their GFR is going to be under 30. So for a lot of these trials, the people that we really want to use these drugs on may not be eligible. But I think of all the molecules, I mean, it may be that the anti-CD38 ones are probably the better ones, or some kind of combination therapy may be what we end up using in the future. But again, it'll be cost. Cost is going to be the big thing.
Thank you.
Any comments from the floor? Any question for Dr. Nathawood? If not, thank you very much for excellent lecture. For all the speakers and all the participants, I would like to close the session. Thank you.
ขออนุญาตเชิญท่านวิทยากรรับของที่ระลึกจากท่านผู้อำนวยการนะคะ ค่ะต่อไปสำหรับกำหนดการประชุมนะคะช่วงเวลานี้จะเป็นช่วงเวลาพักรับประทานอาหารถึงเวลาประมาณเที่ยง40นะคะแล้วก็เซสชั่นบ่ายก็จะเป็น Luncheon Symposium ค่ะจะเริ่มตอนเที่ยง40ในห้องนี้นะคะ
ก็ตอนช่วงบ่ายจะเป็นภาษาไทยทั้งหมดแล้วนะคะก็จะเป็น ก็ขอบพระคุณทุกคนมากเลยนะคะสำหรับเซสชั่นเช้านี้ค่ะขอบคุณค่ะเดี๋ยวเชิญทานอาหารเที่ยงนะคะคาเฟ่เดตูค่ะสวัสดี